Welcome to today's webinar. My name is Carol Reese and I'm a registered nurse and a nursing advisor on the practice team here at the SRNA. Before we start, I'd like to acknowledge that this presentation is being held on Aboriginal land and recognize the strength, resilience and capacity of the Treaty 4 and Métis people in this land. Today, our topic is RN specialty practices, and our speaker will be Barbara McDonald, registered nurse, who is also a practice advisor here at the SRNA. Before we get started, I have a couple of notes for you on how you can engage throughout the presentation. As a viewer of this webinar, you'll be able to see and hear the presentation. Only panelists will be able to speak throughout the presentation. If you have a question, please add them to the Q&A or chat sections. We will be monitoring this area for questions throughout the webinar, and these questions will be answered either live or via typed response. If you wish to send your question anonymously, just check the box at the bottom of the Q&A screen. We will be recording this webinar, and it may be posted to the SRNA site for those who are not able to join today to view later. An email will be sent to you with a link for evaluation, and we hope you will take a couple of minutes to complete the quick survey. So now that our housekeeping items are out of the way, I will turn the microphone over to Barbara.
Thanks, Carol, and welcome everyone. I hope you've had a nice Thanksgiving, and thank you also for acknowledging the territory that we're on. And today's discussion, and I say discussion because I plan to use this format to engage you, whether you are listening live or whether you're listening, if we post this in a recorded fashion, which many of the webinars are posted on our site and a really good resource for you down the road. So this is not the first RN Specialty Practices webinar that we've done, and this one does focus on the evolution. So now the way we have it set up today, I am not able to see who's on, and so I'm going to be asking Carol to work with me really closely so she can monitor the questions that are coming and the responses. So rather than a didactic sort of I'm telling you about RN specialty practices, I really want to engage you in this discussion. For starters, and Carol, you'll have to read out to me, I'm going to ask a question. So when you think of your RN practice, first of all, what areas of practice are you engaged in right now? So the people who have joined us, think about what is your practice area primarily? Is it clinical? And if so, what kind of clinical practice area? So I'm looking for you to, we have in the past actually shared the microphone with other people if they're consenting, so you can actually have talk out loud. So we could do that if you are willing, especially knowing that there will be a recording of this. So if you're willing to be part of that hosting, but let's have you first enter into the chat box your clinical practice area, and also if you are willing to have the microphone be shared with you so you can describe it with your own voice rather than through typing.
Just let you know we have 3 participants or attendees online. So.
Okay, so then I'm hoping that I'll have 3 responses at least, and you can tell me your clinical practice area, and then we can tailor some of the discussion around that.
Okay, so far we have 1 4th-year student.
Okay.
With us.
Okay, and how about the other 2? Can you share your clinical practice area? Okay, so what your next task is to do is to think about a time in your clinical practice where you knew there was something that needed to be done in the interest of the client, and there is a barrier of some sort. So was it you didn't have an order, you didn't have access to the best equipment or the best medications? Think of a scenario where there was a challenge for you to be able to move ahead with what you knew was the right thing for the person.
We do have responses from our other 2 attendees. One works in a cardiac unit and the other has historically worked in an emergency department.
Oh, awesome. Okay, so that's exciting that we can think about RN specialty practices within those contexts. So thanks for sharing that. So think of a time when there's been a limitation to your practice, despite knowing exactly what that person needed, and just park that for now. If there's anybody who's, well, has anybody also indicated that they're prepared to share their stories verbally, that we can share the?
No indication of that yet.
Okay, so think of that time. Is anybody willing to share their story about what that time would be, roughly what the scenario was? If you are willing to do that, you can type it into the box or indicate that we can share the microphone with you as well. So how's that for a webinar that you thought you were just going to attend and listen about RN specialty practices? What I'm trying to do is essentially have a facilitative approach. I've had the honor of going to many places in our province now to have this discussion around RN specialty practices. And my hope is that by the end of our time together, that you'll be very inspired to think about what the possibilities are for optimizing RN scope of practice in your particular area. So your face is saying a lot, Carol, over there.
Sorry, I think I'm not playing poker. One of our attendees had a situation where she needed to administer Vanco, I'm assuming vancomycin, to a non-compliant patient. Patient was going outside for cigarette smoking, but not returning every 6 hours.
Okay.
Every Q6. Yeah.
So that was a challenge with respect to administering the medication, but not necessarily a scope of practice. Like you had the ability to provide the medication, but it was a challenge around the circumstance. I'm thinking of a time where you didn't have an order to proceed, or didn't have the resources to proceed with the care that you wanted to. So are there times when your practice was limited because of the authority primarily? Let's look at that first, around the authority to do what you needed to do in that circumstance. And just thinking about those situations and where had you had the ability, the vehicle to actually go ahead to do what you need to do, that would have been in the interest of the client. So what I'll do as you're thinking about that and jotting it down is I'm going to take you on a little tour then of RN specialty practices. And if you can think of your scenario, we can come back to that also at the end to see how it applies, because I'm really looking for you to talk about what are the opportunities that are ripe for us right now as registered nurses in our practice as it evolves. So you can see, I believe, my screen. The screen has been shared, so you can see that I'm on the SRNA website. Now, across the top of the website, there are 4 primary categories. And what I would like you to do is under practice, so you can either go along with me on your own device, or you can follow me and go later, whatever suits you. But under practice, there are nursing practice resources. So if you click on that, you will see registered nurse, NP, RNA, AP, and cannabis resources. So under registered nurse resources, this is where RN specialty practice will reside, or it does reside. And under RN practice resources, you'll see standards and competencies, guidelines, tools and templates, and ask a practice advisor as the big headings. So under the standards and competencies, we now have new standards and entry-level competencies effective October 30th, so right around the corner. That's an important thing for you to go have a look at, and all of our practice relates to these standards and our entry-level competencies. And perhaps if there's an interest, we'll come back to that at the end of the presentation to see how it relates to RN specialty practices. Then we have standards and competencies for RN specialty practices. So that's a resource that guide our practice in Saskatchewan. And I should say that this framework is unique to Saskatchewan, our RN specialty practices framework. Also, you'll see under guidelines, Actually, under scope of practice, there are RN specialty practice employer guidelines and RN guidelines. As well, you will see under tools and templates, there is a fillable template for RN specialty practices, as well as tools for developing RN specialty practices. And there's also the module. So as you can see on our resources page, there are all the documents that you could ever want around RN specialty practices. And these are essentially the things that permit this to happen in Saskatchewan. Another document worth looking at that is a high-level overview is under About Us, How We Govern, is a document under SRNA Council. And under the council is a policy governance. A few layers. Right here is the one I'm looking for. Document definitions and descriptions. And in this chart, you will see the structure by which we practice nursing in Saskatchewan. So the very first one is the Registered Nurses Act, and it talks about the description of the act and the notes. And then from there come the SRNA bylaws. And then from there, the Code of Ethics, standards, and entry-level competencies. And then council policies and guideline documents. So this talks about the level of authority where everything stems from the act itself. So under standards, you'll see standards like the standards for RN specialty practices. So this is where we have the authority to practice within our province. And it's worthwhile to have a look at the structures that are in place for us to practice registered nursing. So let's get into RN specialty practices and where they fit. So on this chart, which is not posted yet to our site, but is available online under the former Saskatoon Health Region 1104 policy. This is the roadmap that essentially the former Saskatoon Health Region created this drawing, this graphic essentially, of the RN specialty practices framework that was designed. So if you look on the left-hand side, you'll see 1993 to 2015, we had special nursing procedures and transfer of medical function. Now it was in 2008 that was inspired by a letter from a nurse in rural Saskatchewan, a manager, who said, we want the nurses in our diabetes center to be able to adjust insulin, and so we are applying to you, College of Physicians and Surgeons, for transfer of medical function. So the College of Physicians and Surgeons responded by saying, as it turns out, and they copied the SRNA, as it turns out, we don't have in our legislation, the College of Physicians and Surgeons, the ability to transfer medical function to anyone, to any health professional. So there was a series of discussions in complete collaboration in the interests of the clients of Saskatchewan to make sure that the care continued, because there was recognition that there was high-level nursing that was happening, often under a transfer of medical function in Saskatchewan. So the college said, okay, SRNA, let's work together and make sure that you put a framework, a structure in place by which nurses can practice under your own legislation, and that because transfer of medical function will dissolve as of December 1st, 2016. So the SRNA got busy and created the middle column, 3 structures that we'll talk about today and how they relate to RN specialty practices. So at the bottom, you will see, first of all, physician delegation to an RN. So what the college decided is that there are still some things that they need to keep in a bylaw, which they've created, and they are specified through that bylaw, and so therefore they can be delegated from one physician to one RN. And those are things specifically relating to neonatal transport, STARS, for example, and also interestingly, there's a bullet point or part of the bylaw that speaks to cosmetics. So the injection of Botox, etc. So that's not the theme of today's discussion, but be aware that there is a document, a guideline document that describes the role of the registered nurse in a delegation situation and what the requirements are. And that's specifically through the bylaw, through the College of Physicians and Surgeons. Now, the other two that relate specifically to the SRNA are RNs with additional authorized practice and RN specialty practices. So RNs with additional authorized practice are those that are specifically in the north. It's a formal education requirement, and they can diagnose and treat and prescribe for, excuse me, limited common medical disorders. So those limited common medical disorders are defined through clinical decision tools. So at this current moment, there are 68 clinical decision tools. They're also on our website, and you can see what they are. So those nurses in the north who have this designation, have gone through this process, can diagnose, treat, and prescribe for limited common medical disorders with those clinical decision tools. There are things like otitis media, acute neck pain. Anyway, there are 68 of them. They're worthwhile having a look at. Now, RNs with additional authorized practice, there are 118 currently in the province. So the clinical decision tools are created by the SRNA, and the responsibility rests with the SRNA for the oversight of those clinical decision tools, as well as tracking the formal education of the RNAPs. It's a course through SaskPoly, 3 courses that RNs will take to become additional authorized practice, and there's a requirement for number of hours that are maintained, etc. Now, the thing that really excites me and brings me to work each day, I have to say, is RN specialty practices. And that is because this is a framework where registered nurses who are practicing beyond entry level. So entry level, I've already mentioned the entry level competencies that are on our website. Those are clearly defined in 9 roles. So that's what our schools prepare nurses so they are ready for practice. And then, so that's entry level, and that forms the foundation from novice to expert for registered nurses practicing in our province. And in fact, that document, the ELC, entry level competencies, is a national document where it's standardized across Canada. So once you're beyond entry level, RN specialty practices are likely to be in place. So these are the skills, treatments, and interventions within RN scope that have specialized competencies which are obtained beyond entry-level practice education. So they range from relatively straightforward to highly complex. And this then relates to close to the 11,000, almost 12,000 registered nurses that we have in the province. So the magnitude of the potential for optimizing RN practice in the interest of the client is incredible. So when we think about what's possible through RN specialty practices, and that's why I had you at the very beginning think about a time when you might have been held back. Well, perhaps there's the possibility right now within RN specialty practices in working with your employer to create those protocols to meet the needs of the clients that you're serving, especially in the highly specialized areas. So RN specialty practices, on the right-hand side, you'll see are 2 pathways. Excuse me. So we have RN procedures and RN clinical protocols. RN procedures are those, now the first bullet point I'll take you to is right here, with a client-specific order. Okay, so the authority is coming from a client-specific order, which means it's for a particular person, and that even includes, what am I thinking of, where you have a checkbox, why can't I think of the language around the order sets? There you go. It's coming, it's coming. It's like the magnifying glass was, or the hourglass was turning around and around while I found that one. So that is, even if it's an order set, it still has a person's name on the top. So it's checkboxes saying, yes, these things pertain, these orders pertain to that one person. So, this is a client-specific order. For RN procedures, this is relatively straightforward to moderately complex, lower potential for unintended outcome. So remember, it's still beyond entry level, but it's a procedure, and there's a client-specific order. Now, there are RN clinical protocols, and there are 3 types of RN clinical protocols in our current structure. If you go to the bottom one here, Advanced RN Intervention, you'll see that it is very similar to the RN procedure. in the sense that it has a client-specific order. Okay, so the authority is still a client-specific order. It's for a particular person. All right, so this ranges from, the only difference really between an RN procedure and advanced RN intervention is the complexity or increased risk for unintended outcome. The authority is still the same with respect to the client-specific order. Now, my favorite part of this whole model is right here, health services / program. This is where you're treating, we have the potential as a registered nurse to treat a client population with a medical directive. So having that population described, I'm treating this population, and I'm able to do this, this process for that particular person within that client population. So the first ones that they designed were things like immunization programs and diabetes education programs, teaching insulin self-management. So you didn't need a client-specific order for each one of those people. Now, that was kind of the low-hanging fruit when they created this model when they launched it essentially in 2015. They thought about programs in the sense of, where do we have a transfer of medical function in place that we need to keep the work going? So let's get an RN clinical protocol in place that has a medical directive that keeps that important work going. So the very first RN clinical protocols under a health service / program were those designed for that, keeping the work going and having the registered nurse do the work for a client population. Now, this is the area of the model that has evolved most of all in the last few years, because our sense of what is a client population and what can a registered nurse do within that client population is very much evolving. For example, I remember the day that I tell this story every time, so if you've heard me speak before, you'll know the story is coming. But the day I picked up the phone, it was a recovery room nurse in an urban center who said, I have the ability to do ultrasound on the bladder post-op to see if there's distension, but I don't have the authority to put in a straight cath. So it was an interesting scenario where we've advanced in so many ways, and then yet, wow, we have to get an order for that straight cath. So what the current practice was, well, I'll put in the straight catheterization and I'll get an order later on, or I'll wait for an order, which puts the person at risk with the distended bladder. So there was potential, and I honestly don't know if they've written this protocol or not, but there's potential for creating an RN clinical protocol that describes that whole thing in the recovery room. So that was not the standard sort of program area that had been thought of when this model was first developed. So here we have a recovery room where it's a health service, which is recovery after a surgical procedure. It's not a program per se, but it's a health service. So at that time, I was really emphasizing the slash between health services and program, because it's not a health service program, it's a health services / program, which made me think quite differently about what the potential is for this within this model. So working with the SRNA team, we came up with yeah, sure, that seems as though it would fit, because the authority would be then for this recovery room nurse to have a RN clinical protocol in place that describes the whole process around assessing for distension and then managing that well within the scope of the registered nurse. It also triggered some questions around, wow, where does it ever say that we need an order to have it put in the catheter? So it's causing some thinking around what is the sort of upper limit of our scope, and how do we push the ceiling of where we are in order to optimize client care through registered nurse practice. So there have been a number of examples since that time. And one of them was featured last year at our conference, where one of the northern communities has designed an RN clinical protocol for INR monitoring and warfarin titration. And that one extends past a particular area. So not just home care, but also the RNs working in the clinic. So they have one clinical protocol that spans the whole community in the northern Indigenous community, where now through that RN clinical protocol, there's point of care testing, all based on the evidence. And So point of care testing and then titration of the medication right at the bedside. And that clearly is in the interest of the client. Worked into that protocol also are the Indigenous components around consulting with an elder to understand the sacredness of blood and what processes need to be adhered to in order to have culturally sensitive and cultural humility built into that process. So this is creating all kinds of potential, and we're going to talk about that a little bit more as well. Also in this model, we have health condition in an emergency. Now this one, I would say, has not been utilized as much over the last while, and here's one of the reasons. It was designed to say, go ahead and save a life without an order. So we were finding that some of the protocols that were being written, say in a rural ER, there was one that was written for interosseous insertion for pediatrics, where the IO insertion would occur to hydrate the child, and it was written really clearly around that RN clinical protocol. In that case, we decided together essentially that maybe having the medical directive associated with that would strengthen it rather than going ahead and doing that without an order. So essentially it was put under health services / program. And in that case, it's emergency health services, even though it was a health condition in an emergency. So I'm not sure, I haven't had as many discussions recently around this health condition and emergency part of our model. The two pieces for RN specialty practices that are clearly being used most of all are these two here, which is advanced RN intervention, where it clearly is a client-specific order, and a health services / program, where it's a client population with a medical directive. So I will take you to back to our website, and we're going to go to the resources, and under practice, you'll find practice resources. And then I'll take you to here, and we'll look at the template that's currently there. This is a template that has been quite helpful for people creating RN clinical protocols. So it's a Word document. You can see that it downloaded on my desktop, and that's intentional so that it can be used for you to be able to create your own document. So this one was initially developed for two reasons. One, to create a template that would support any RN specialty practice, and also, secondly, was to provide a response to our need back in 2017, almost 2 years ago, to support the distribution of take-home naloxone kits. Now, what's interesting and demonstrates this evolution once again is that this clinical protocol that the SRNA developed essentially to support that provision of take-home naloxone kits has now evolved. And this is now considered by the SHA especially to be a entry-level practice. So, so no longer requires an RN clinical protocol for this. So that's an interesting evolution as well. So at the very beginning of the template, we've created a box, essentially. There's almost like an at a glance, everything that you need to know about an RN clinical protocol is right here, or an RN specialty practice is right here. Now this was inspired by my work with the corrections, provincial corrections, because they were also creating RN specialty practices documents more than 2 years ago with respect to that environment for practicing. And they had a number of RN specialty practices protocols to put together. So they said, you know, we said together, wouldn't it be handy to have something at the very beginning that you can tell exactly what this falls under and what competency requirements and so on. So essentially came up with this chart. And you'll see then that there's a title, RN Specialty Practices. So this is the title of that particular RNSP. On the right is the effective date, the schedule review date. So how long after this is created, how recent or how soon will we need to well, you need to review this RNSP. Now, the other thing that I want to emphasize is that while the RN Specialty Practices documents belong to the employer, so together with the registered nurses in their practice area, the registered nurses who are the experts in their field, they create the documents and provide that opportunity for practice. So we were a little hesitant to create a template because then it looks as though the SRNA is saying, here's what you must do, when in fact, the SRNA has provided a framework to say, this is how this can happen, go create your protocols. However, having this template, this structure, was helpful for many to create the RN clinical practices protocols in their area. And right now, if you're part of the SHA, we're in ongoing dialogue with them around RN specialty practices and optimization of registered nurse practice. And the best thing for you to do is to gather the evidence and to take it forward to your managers, who can then take it forward to the professional practice group, excuse me, through the SHA. And if you're not with the SHA, same idea where you gather the information and take it forward as part of your knowledge and skill and judgment as a registered nurse to provide the best standard of care for the clients you're serving. So back to the template then, on the top, the effective date and the review date. On the right is the authority. So this is, in this case, was, and now it wouldn't even be an RN specialty practice because it's deemed entry level. But at the time was an RN clinical protocol with a health services / program with a medical directive. And then we also laid out what the client population is. So who are you serving through this RN specialty practices document? And who was it signed by? So who authorized the medical directive? And the medical directive can be signed by either, so far right now, either a medical doctor or an NP. And on the left-hand side, who prepared this document? Who was it approved by? And what was the date of that approval? Now, in the example that I told you about the INR monitoring and warfarin titration in the Northern Indigenous community, it was very cool to see, prepared by, had a list of about at least a dozen names of all the registered nurses and RNAPs and NPs, excuse me, and an elder prepared the template. And then it was approved by the chief and council in that community. So that was a really cool demonstration of that collaboration. And that is probably one of the most important features, is actually engaging registered nurses at point of care who know the very best about their practice area, and having them review the literature and come together to determine what is in the best interests of the client, what is the evidence-informed best practice that we need to include in this protocol. Then it describes which RNs it pertains to and what are the competency requirements for that registered nurse or whoever's going to provide this particular care. This ties also nicely with your competency CCP because you can tie it in with the competency that's required for your RN specialty practices and make it part of your CCP if you choose. So in this template, we also have the definition, scope, risks, process steps. And so in these process steps, you'll see the nursing process, nursing assessment, therapeutic actions for plan and implementation, and then evaluation. Also, what will the documentation be and communication? And then here's the medical directive. And, you know, as we're talking about evolution today, there are some things that I'm thinking about with respect to the language. So when we call it a medical directive, often it's thought of as being medicine as in physicians. So then when you look at, just for 1 second, when we look at this again, when they're seeing a medical directive in the health services program and they see transfer medical function, they think, there's no difference. There's no difference. So they don't call it a transfer medical function anymore. It's just a medical directive. And this is where we need to come together and really see the difference in a registered nurse model like this, where there's huge potential for, first of all, registered nurses are going to be writing these protocols and taking them forward. Already the authorization can come from a medical doctor or NP, and in the very near future, there is the movement already across Canada, and we certainly have it here within our RN AAP, where RNs will be able to prescribe. So it'll be within this health service / program area that RN prescribing will live. So let me give you an example that's ongoing right now, is that with our HIV nurses, they are designing an RN clinical protocol where they're able to give medications, so provide medications within the context of their care. And perhaps in the near future, if it's mobilized through our act and through our standards, that then they will maybe in the future be able to prescribe those medications for that client population. So there's quite a difference between transfer medical function and the ability within the health services / program to optimize nursing practice in the interest of the client, because we have the knowledge, skill, and judgment to be able to provide that care at a very high level, and have actually for some time already. So if we look then at this medical directive, perhaps the language needs to be authority or prescriptive authority. So those are some of the things that I'm thinking about as we reevaluate the standards and the model to be able to suit that evolution moving forward. As it is at this time, it says, I, so-and-so, an authorized prescriber in Saskatchewan, agree with and authorize this clinical protocol as written. So, so that's what a medical directive would look like. And then probably the most important thing of it all, and it's at the bottom, so only because that's typically references, but essentially the references show that it is the up-to-date, evidence-informed best practice that we're applying to this particular client population. So when the nurses who are coming together to create that INR monitoring and warfarin titration, they reviewed the literature on point of care testing for INR, the algorithms for titration of the medications, and they all reviewed that literature together when they prepared and created the protocol, which I think in the end translated into greater uptake when it was actually formalized, rather than sort of a, for lack of a better word, top-down approach where the protocols are created and then the registered nurses are told this is what they're going to do. So we need to find a way to mobilize registered nurses collectively. I think that coming together in a way where we bring the home care nurses together or emergency room nurses together virtually, potentially, to discuss what would make it much easier to meet the needs of our clients based on the standard of care that they deserve regardless of where they are and the evidence that supports that practice. So these are really exciting times to think about how we optimize that practice. Another example would be the medical health officer and nursing manager in the north called me last winter to say, is there any way that registered nurses could provide Tamiflu for those who are at risk for flu in the north? So we're talking about a particular Indigenous community in the far north. And essentially when we looked at what's cost effective, what does the literature say, can nurses identify flu-like symptoms, I believe that protocol is being written by that particular MHO along with the nurses to create a protocol where they will have with them Tamiflu to be able to provide to those with flu-like symptoms, because there's such a narrow window of opportunity for having it be effective. So that is a really good way to think about how registered nurses, who are the largest group of health professionals in the province, can truly provide that care in a timely, effective way. And always with the interest of the client at heart. So the 4 questions we ask is, what is in the interest of the client? Where will the authority come from? What does the evidence say? And what are the competency requirements for the registered nurse? So let's have a look to see what your questions are and comments.
Okay, I actually have some scenarios here where an RNSP would probably be appropriate. Anyways, read you the first one. Patient had a reaction to an antibiotic, but there was no standing order for Benadryl or other meds that are usually used in that scenario. This made it more time consuming to deal with an immediate reaction.
Ah, that's a perfect example of something that can be done right now and is being done right now. So there are clinical protocols in place for anaphylaxis outside of immunization, because certainly anaphylaxis is built into the programs with respect to immunization, because it's anticipated that anaphylaxis might be part of immunization. So certainly having an anaphylaxis RN clinical protocol is important, because you'll be able to provide that care effectively right away. So at the point right now would be an RN clinical protocol that enables treatment of anaphylaxis, and the medications are specified through that RN clinical protocol. And I would bet that they exist, so it's a matter of how do we connect. You may want to choose to put your question in our community of learning, community of practice, right, COP. So to put your question in there and see if you can get someone to share their anaphylaxis protocol with you, but that makes perfect sense. And in the near future, RN prescribing, so that you could essentially prescribe that within the RN clinical protocol yourself.
Okay. We have another one here where it says, I had an occasion where a patient with a known history of asthma presented to the emergency department. This patient presented with obvious respiratory distress, decreased oxygen saturation, and had run out of his Ventolin at home. As a triage nurse, I wanted to give him Ventolin, but was unable to start treatment at triage. This person had to wait to get into a room, be seen by a physician before medication could be ordered.
That is sad. Like, so you had full capacity to know exactly what the person needed. And in fact, the system, the way it was structured, is delaying good care. So an RN clinical protocol certainly for asthma, clients with asthma. And in fact, that's one of the clinical decision tools that is one of the ones that the RNAAP in the North will treat asthma. And they have that laid out essentially with all the evidence behind it. So it's a matter of getting those things in place and starting your list of what are those examples, and that's why I want to start with that, thinking around what if I could do something differently, what could I do? Starting with those examples right now to facilitate good care right now is possible through RN specialty practices.
I have one more question. It's kind of large and global, but I think some RNSP could fit into this. Trying to get a hold of doctors when they're not on the unit, not calling back, so unable to get orders and probably manage patients' care.
And I suppose it depends what you're talking about with respect to that care, but looking at the client population, you know, if you know what they need, and often it's the case where you know how you've said to the prescriber, this person needs this and they need this much of this and so on. We have that knowledge and we have the evidence that supports it. What's in the best interest of the client? What does the evidence say around that authority and what happens other places? And even if it doesn't happen other places, what is in the interest of the client and how do we make that happen in the most effective way for them? So thinking about what is it that you are going after medication-wise or treatment-wise, and is it within the scope of practice of a registered nurse? Certainly, if you already have that thought, then how can we make that happen in a way that's safe and, you know, not totally outside? It's not outside of the scope of practice of a registered nurse, but as I keep calling it, pushing that ceiling to ensure that we are practicing to our full scope in the interest of the client, using knowledge, skill, and judgments consistent with the registered nurse.
And this might sound, you know, pretty low level, but I know, Barb, you've brought it up other times where diet is tolerated.
Oh, yes.
Who says we need to get an order for diet is tolerated? You know, maybe it's a new admission. And I understand there are things that doctors have to order that are beyond our scope. But like you say, some of those preliminary, low level kind of things could be something that's, you know,
yeah, absolutely.
RNs could do.
Yeah, that's a good point. So there are things for sure that are in legislation around who can prescribe what, especially when it comes to medication. The other thing to think about is in NIHB, now they've opened it up for registered nurses to be able to authorize certain things. So NIHB is non-insured health benefits for our Indigenous clients across Canada. And now the registered nurse has the ability to authorize certain things like mobility aids and so on. So that increases access significantly. So that's something to explore. But when it comes to needing orders for things, I think we've lived in a world in the past where it's the order says dressing change or diet is tolerated, or those sort of vital signs. Those sorts of things are well within our practice that we need to define and determine. Like the catheter, for example, what are the pros and cons, and do we actually need to have authorization through an order for all of those things? And of course, everything has to be put in place with respect to policies in the institution that you work in. But these are the discussions that need to occur to move that care forward in the interest of our clients.
That's all the questions I have. Does anybody have anything else they'd like to run past Barb? She's a very knowledgeable expert, and this is her passion, so this is the lady to ask.
Yeah, this is one of my passions.
Bagpiping's the other, I know that. But
and diabetes.
and diabetes, yeah.
But yeah, so of course my family. But yeah, if there's anything at all, feel free to connect with me, bmacdonald@srna.org. You can also connect with any of the practice advisors. So I'm not sure if that's part of Carol's wrap-up spiel, but practice advice at srna.org. And there's a phone number that she'll be able to provide for you as well. And we also I can come out and speak to large groups to inform them about our specialty practices, or small groups. We can have it over the telephone. We can have this conversation that's tailored to your work and your environment. So keep that open as an option as well. So thank you very much for listening to me today. And I'm sorry we're a little late to start. Technology always challenges us a little bit, doesn't it, sometimes? And so thank you for your attention, and I look forward to our discussions in the future.
Okay, and I, Carol, would like to thank all of our attendees for providing us with some information and providing us with some questions. It stimulated some great discussion, and as Barb said, she'd be happy to come out and talk about this more. So thank you very much, Barb. Next week's webinar topic is Toolkit for Managers, and that will be Donna Marin and Terry Belcourt that will be doing that. If you've missed a webinar, you can view them on the SRNA Vimeo or YouTube channels. And thank you again, Barb, for joining us, and we'll see you next time.